Hello, I'm Mark Rickenbach. I'm a GP near Southampton. I practice of about 17,000 patients with 8 GP partners and a team of about 50. And I am going to talk about continuity of care for healthcare workers as patients. And this is part of a presentation that was done at the Wounded Healer Conference in June of 2024. And this Wounded Healer Conference is run by the NHS practitioner health team who provide support for those working in healthcare to address mental health and ongoing issues that are related to mental health. And I'm a visiting professor at University of Winchester and a GP trainer and past associate dean based at the GP education team. And we're talking about continuity, and I'm going to ask you two questions, or going to address two questions. Why continuity of care for you and your patients? And how to achieve continuity of care. I'm going to start with as a GP practice, but then I'm moving on to for yourself as a patient. And when I'm talking about this, I'm talking about all patients and all people, but I'm going to have a bit more of a focus on those who are working within healthcare. And you can find information on continuity of care at the www.cric.co website. And you can contact me on the email address there, the NHS address, if you want to join the community that looks at continuity of care and gives support and advice on how to find continuity of care. Or if you want to join the or access the toolkit on the RCGP website. So I need to acknowledge the context of this and say that continuity of care is a challenge because of the workload and the numbers at the moment. So at the moment, continuity of care is going down generally, not in all areas. Some areas it's going up. And this is partly because of the workload that's increasing for general practitioners, partly because of the reduced GP numbers, and the larger organisations that are taking place with merging of practice or primary care networks coming together, or salaried organisations. And there is a general shift and pressure to move towards a more transactional care with the targets that we're currently set to maintain income in general practice. So transactional care, where you're just dealing with the test, you're responding to things that you have to do, as opposed to listening to patients and working through what the real problems are. The government needs to understand and listen that continuity of care counts, that it makes a difference, that GPs are cost effective. Not only are they seeing patients face to face, but they're also dealing with patients on their list, if they're salaried or partners with a list. And they provide innovative leadership and management within their practices. There's at least 3 different roles, and to replace a GP, you're going to have many more roles. Indeed, you can see that with the current additional roles that are taking place. The paradox of continuity of care, as outlined by Otto Marsing, who's a researcher in the Netherlands, is that as workload increases, the continuity of care is falling, and there's therefore higher costs, more urgent care, and greater workload. And we're going to see the evidence for that in a minute. So the paradox is, as workload increases, we actually need to put more continuity of care in, because that's a way to reduce costs, reduce urgent care, and reduce workload. And here's the evidence. I have a picture of a wall there because I see it as a high wall of evidence that's there. It's been built up brick by brick over the years. But most of this evidence is reports, it's observational data, it's qualitative data. There is randomized controlled trials, but only a few, and most of those are in midwifery, where there is evidence that increased continuity reduces interventions and complications during pregnancy. The point about the evidence base as it exists is it's consistent and all in one direction. So patients are more satisfied, they follow medical advice better, they take up preventative medicine better, they have a better relationship, they report, and as a result, they feel they receive a good quality of care, or they were shown to receive good quality of care. There's reduced attendance at A&E and reduced hospital admissions associated with continuity of care. Indeed, Barker pointed out, and I'll paraphrase it, that if a person sees a GP 2 more times out of every 10 consultations, there is an associated 6% decrease in admissions for ambulatory care issues, those things that a GP sees. And there's benefit for doctors as well as patients. There's accumulated knowledge of the patient over time so that you can start the consultation without having to go over things again. And you know things that will make a difference. There is greater professional satisfaction, partly because of that. There is better problem recognition and better quality of management of care. There's less conflicts of responsibility, who's looking after this patient, less patients bouncing around. There's reduced A&E admissions and outpatients, as we've said, but that also reduces your workload. It reduces your costs, reduces your prescription costs. It reduces avoidable harm, and there's less medical legal risk as a result. And if you want to visit this a bit more and use the links, go to continuityofcounts.com, which is the Exeter website, or the docuric.co website that I have written up. And lastly, mortality. Morbidity is reduced, but mortality is also reduced. And there's a significant study in Norway that Sandvik did, which showed that there's a dose response. The more continuity of care you get, the less morbidity and mortality. And this is proportionate. As you increase, the mortality falls. Up to 15 years, there's a 25% reduction in mortality. And I think that's pretty impressive, really. So if continuity of care was a drug, we would all demand it. That's Martin Marshall, the chair of the RCGP. Are there any risks? Well, first of all, the research here is based on GPs. So we have to extrapolate it to other healthcare professionals with continuity or secondary care. But I think it's valid. There is potentially a delay. That's what's been reported anecdotally in some papers. But actually, when I looked at it in more depth, there is no overall delay to management or treatment. The delay appears to be within the first week to referral. And I think that's probably related to the fact that a GP who's got good continuity is working up the referral and checking it's appropriate. The other thing is that heart sink feeling appears to be more of an issue if you have continuity of care. Only initially, and once you get to know the patient, that heart sink feeling resolves. But it's when you're setting up your practice for continuity, you're seeing the same patient more often, and as you are attempting to resolve them, sometimes you get heart sink feeling. There's advice on handling this at the website and at another talk I've done. So an example or two. 3 times per wear is the rule on the DocRec website I've outlined, because after 3 times attending with the same issues, the GP needs to raise their own concerns, look at things much more carefully. The first consultation, they might be looking at duration and severity of symptoms and handling them as much as they can. The second consultation with the same problem, they might be looking at patterns and looking back, see if there's any previous consultations that are similar. But the third time with the same presentation, they need to be thinking more carefully. Often with non-specific symptoms, you might be missing something. And an example is urinary tract infections. If the patients come up 3 times with urinary tract infections and they haven't done before, and there's no previous pattern like this, you need to be thinking why. Is there some underlying condition in the bladder? And this is a common catch And recently, due to continuity of care, this has been picked up and a diagnosis of bladder cancer has been made and treated. So 3 times beware. The continuity of care programme, which has led to some evidence, a lot of evidence about how you can improve continuity, ran from 2019 to 2021. That's 3 years. It was extended because of COVID. Over this time, nationally, the continuity of care dropped, but within the programme, the continuity of care was maintained or increased. And this programme took place across 500,000 patients and 5 different sites in England. Each site was seeding continuity of care to those around it by using facilitators. And it is reported in those studies that the joy in work made the workload easier. Doctors felt positive about it. They were satisfied and enjoyed their job more because of it. And access actually improved because with continuity, they released appointments because not so many appointments were required. Something like an 18% reduction in appointments and a 5%, 18% freed appointments, and a 5% reduction in workload. So think continuity of care with every consultation. Don't have to put it in place, but just offer it to the patient, suggest how it works, or put it in place. Another example, dementia care in care homes, 35% reduction in admissions and delirium, and a significant reduction of incontinence with continuity of care. You can go to the continuity of care toolkit, which is jam-packed with resources, and this is an example page. This is a sort of master page where you can access all the other points. And it's broken down into 6 stages, and as a GP or primary healthcare team member, you can work out where you are in these stages. Are you starting out to look at continuity, or are you at the point of measuring it in more detail, or are you actually designing changes that will help you to increase continuity? If you're starting out, it's a question of talking to everybody and explaining why, the whole team, patients and all staff. And if you go to each section, you can see some refinement of what to do and where to go. So you go to the RCGP website, just put in a search for continuity and you should find this toolkit. So now we're going to come to patients and you as a patient and how it feels and what you can do. And the common statement I hear on the street or when we meet up with people is, I never get to see the same doctor. But the reality is most patients see the same GP 20 or 30% of the time. And a good level of continuity is 50%. So you only have to see a patient half the time. You can use the primary care as a team. But large and small practices do achieve 50 to 80% continuity of care. And practices are coming on board and achieving that. So I'm going to pose a couple of questions for you to think about. You can pause the video and think about these things and then come back on. Do you want continuity of care as a patient? Do you want continuity of care as a patient, having heard the evidence? And how do you get continuity of care for yourself? What can you do to do that? I'm going to give you a couple of minutes. You can stop the video, come back, you can just think about it, make some notes or discuss it. So welcome back. I hope you've managed to think about your question. Do you want continuity of care as a patient? And how do you get continuity of care for yourself? So what can you do as a patient? You can ask about the best contact route within your practice, and it can vary from practice to practice. Sometimes it's e-consult or the equivalent electronic consultant approach, or it could be by phone, or it could be by sending an email. And it helps to find out when that is best. Sometimes it's at weekends, so it's addressed on Monday. Sometimes it's in the mornings, but just check when. Ask who your usual named doctor is. Check their role. Are they temporarily there doing maternity leave cover or as a locum? Or are they a long-term GP partner or GP salaried doctor? Check their days of work. Do their days of work overlap with yours? Make sure they do. so that you are free to attend appointments, that is. And use the same GP name over time when you're asking for appointments or discussing things. And then every now and again, check they're at the practice, because sometimes they may move on and you may need to ask for a new named GP. Think about updating pre-consultation. You can send in key information and questions beforehand. You can send in your ideas, concerns, and expectations, even better. Some GPs might see that as extra workload, but actually it helps them to sort out the consultation beforehand to prepare, or even deal with issues in the consultation. And provide a list of those issues, and which be prepared to understand that you can only address one or two of those at the time, and it may be a staged consultation if you have got some sort of list there. Mention your role as a healthcare provider. So I'm now talking about healthcare providers as patients, and there's a bit of a debate about whether you mention your role and how you mention it. I think it's better to mention it fairly early on. You can apologise if you want, say, sorry, I'm a doctor or a nurse, and then say something like, do you explain it in full as you would anyone else? And then listen actively. And equally, as a GP doing a consultation, you might want to ask about this and bring this out earlier on and discuss your approach. In general, they advise to avoid a corridor consultation. That is meeting somebody in the street or in a building and saying, oh, please, can you tell me, what do you think? But it may be an approach you could use. And if you do, you apologise and perhaps suggest a more formal consultation. I've used the word apologise a couple of times here, because the other approach, of course, is to be very demanding and say, I must have this, I must get my appointment. In the short term, that might be productive, but in the long term, it may not be so. Is there a formal route or an informal route to get healthcare practitioners through the system quicker? I don't know. I think they may have been in the past. But bear in mind that there are other routes which are formally there for you, like health practitioner, NHS health practitioner, which does provide support for you as a healthcare worker, doctor or nurse or GP. So, as a healthcare provider and patient, do you go to your own practice or another GP practice? Well, I would advise another GP practice, because you get more confidentiality, but you may feel that you get a better response from your own GP practice. However, there are issues here. Do go to the DocGrip website for confidentiality information about the different levels of confidentiality. But there's confidentiality within the practice. Have you got systems in place for that? And are the appropriate people seeing records and no one else? There's local confidentiality. They shouldn't be discussing it outside the practice, but you may feel that is the case and feel uncomfortable about it, even if it's not happening. And then there's a question of routine illness may be okay, minor illness might be all right in your practice, but what happens if you've got severe illness, physical illness, or mental health issues? These two things might raise a question of competence to work. And then you've got a conflict of interest where the practice is wanting to sign you off sick, but that might not be appropriate, or vice versa. And then, as I mentioned, NHS practitioner health. If you are struggling, you can get a confidential service there, independent GP outside your area, independent counsellors outside your area. If you want to learn more about continuity of care, you can join the continuity of care community. Just email me and you can contact others to get support on how to improve continuity within your practice or handle continuity as a healthcare provider and patient. What else can you do as a patient? Well, we've talked about relationships that builds trust between you and your doctor, and it leads to both of you putting more extra effort in. So patients are more likely to follow the advice, and GPs are more likely to investigate and put in the effort. Best to start now. It's harder to do when you're unwell to build up continuity of care. Um, uh, and discuss continuity in a positive way rather than I haven't got it. How can you get it? And ways of moving it forward. Perhaps even support your patient participation group and your practice manager in promoting continuity. And thank yous do help. It builds that relationship. It doesn't have to be much, just a note if you want to. And if not, just a smile, just being positive and saying thank you as you leave the consultation makes a big difference. Some people use gifts. Some GPs feel uncomfortable about that. But I must recall that I do remember patients who've perhaps given me tomatoes in the summer season. And it may be that I did put more effort in for them. I hope not. I think I did it equally for everybody, but I do try. And that may make a difference. It's a bit of a contentious issue. So both the patient and the doctor need to work for continuity. And patients are prepared to wait for the usual doctor. When they did the surveys in the Health Foundation Continuity of Care programme, they realised that actually everybody was prepared to wait, whatever their age. However, younger people had more minor illness and were prepared to see other doctors as well. So continuity of care can be achieved, and it is being achieved currently. And an example is the Living Well Partnership in Southampton, but there are other examples around. They have a named usual GP, they have a micro team, and micro teams is another approach where the evidence base may be coming out soon, but we think they make a difference. In Valentine Health in London, they managed to increase continuity of care from 30% to 60% using a micro team of a couple of doctors, some nurses, and a healthcare practitioner. Those teams may change over time, but you maintain the continuity by revisiting it on a regular basis. And in Living Well, the urgent care team sits alongside the micro team and they work together on handling the patient. So tailor it to your practice is the message. Work out where you're at now and then move forward. Involve everybody in the practice if you want continuity, including patients. And we've talked from a patient perspective and a doctor perspective today. Have a named GP for everyone. You should anyway, but actually use it actively. And have some sort of measurement process in place to feedback on continuity of care. 50% of the time is good. These feedback systems are now in place on clinical systems like EMIS. And don't forget the continuity of care community if you want help. So finally, what steps are you going to take? Continuity of care gives you a longer, better life and saves resources. So think about it from the patient perspective and the GP perspective. Do use the toolkit, the links there, or search RCGP and then community. And think about having a lead in your practice. And a facilitator locally makes a difference. Someone who can support people putting in place continuity of care. Talk to your integrated care board or whatever organisation is currently supporting you in the local area. So if you have questions, do email me at my NHS address. And thank you for listening. I hope that you can increase continuity of care for yourself as well as your practice.